walk through some of those scenarios. And one of the things we see a lot is lentigo maligna, right? And those are the really early I mean, I consider them, they are just melanoma in situ and very early stage of lesions. And they commonly found on the face, on the exposed site in elderlies. And treatment is usually the first line option, but there are many times the patient is too frail, too old, and we actually consult our radiation oncologist for using this modality. Can you just comment on, like, what that process is like and how effective is it for radiation treatment for
Sure, yes. As you've mentioned, these are this is a disease that occurs in elderly patients in sun-exposed areas, and in addition, they can be fairly large lesions, and so surgical management could be either medically contraindicated or disfiguring. And so this is the case where, as a radiation oncologist, I could be called upon to treat. And we actually have a fairly good track record in terms of treating and controlling this disease. The Princess Margaret series is probably the most talked about series for lentigo maligna in the elderly. And they reported about 80 to 90% control rate with the use of radiation treatment.
So can you comment, like, what kind of modality, and let's just say I'm a patient, and I went to see my surgical oncologist, I went to see my Mohs surgeon, and they tell me, this is too big and perhaps you're going to go see a radiation oncologist. I'm come to your office, right, with the lentigo maligna on my face. How does that consultation process go?
Well, I would talk to the patient about the radiation as a treatment option, and they probably discussed the surgical option and sort of the extent of surgery that would be required with their Mohs surgeon or other surgeon. And as far as the process of radiation, I would describe a planning session, which would typically begin with an appointment where we would make a thermoplastic mask that would fit over the patient's face. And this is a material that, when placed in a warm water bath, becomes pliable. And then it can be stretched over the face and kind of form fit, a little bit like the Terminator, if you've ever seen that movie. And it hardens as it cools, and it helps the patients to get into and maintain the treatment position.
Okay.
After that, we get a CT scan, and that gives us a map of a patient's body, of a patient's anatomy, and that information goes into the computer planning system. And with that map, or specifically electron density map, we can calculate how a radiation beam is going to interact with tissue. It typically would take us a few days working on the computers to develop a radiation plan, and then the patient would come back for treatment. When they had treatment, there would be trained therapists operating the machine who would set the patient up on the table in the mask. The treatment plan would be verified. I would be supervising everything that would happen to them. And when they had a treatment, we typically, for lentigo maligna, for example, would be using an electron beam, which is a charged particle radiation, which still is ionizing radiation, so it's active against cancer, but it just penetrates superficially into tissue, and then the energy basically stops. So it's a really great way to treat skin lesions.
So the most important thing is, for patient who's listening to this, is the electron beam is superficial. It is not going to go deeper into the bones, the muscles, or the brain, right? Is that correct? I mean, I think this is one of the questions most people have.
Exactly. And we can modulate the energy of the electron beam. Sometimes we will use a bolus material, which will allow the beam to build up, but also keep it from penetrating too deeply into our target structure, so that we can spare the normal tissue behind it, which, of course, in the head and neck area is always crucial. So we want to do that as much as possible.
And I know that, you have a set dose. You don't deliver it once, you deliver multiple fractions. I mean, multiple episodes, right? And then one of the questions is, uh, how many episode, how many fractions typically? And then what's the frequency? I mean, I know it's 2 to 3 times a week. And also the question is most patients have is how much time do I need to lie there with this terminated mask and something? Is it something quick or something like what is that like?
So fortunately, a single treatment with radiation does not take a long time. After the patient's set up on the table, in this case with an electron treatment, we have a beam that's going to be applied directly to our target area. The whole process may take about 10 minutes, including all of the setup time, with the beam being on maybe 30 seconds to a minute or so. During the treatment, you don't actually feel anything. So each individual treatment is pretty easy to take, but we typically do repeat these treatments. And this is another way that we can protect normal tissue. So the first way we have to protect normal tissue is by altering the distribution of radiation. And we can do that by shaping our field to match the target area, as we were discussing, modulating the depth of penetration of the electron beam. But very importantly, we have this dividing of the dose into lower doses, which we also call fractionation. And that's a very important method of protecting normal tissue. And in fact, it's the reason why we have a radiation treatment at all. So what we're doing when we're dividing the dose or fractionating is taking advantage of the body's natural ability to recover from lower doses of radiation. And we're all born with this natural ability because we basically live in our radiation environment. Even, unfortunately, as we're sitting here today, we're being bombarded with cosmic rays. And if we didn't have these natural abilities, we basically wouldn't survive as a species. So when we give a low dose, we're allowing the normal tissue to recover in between each dose of treatment. Whereas cancer cells, which are disorganized and have lost these exquisite abilities to repair from radiation effect, are killed off. So each subsequent dose will allow us to affect both normal and tumor cells within our target volume, but the normal cells will recover, whereas the tumor cells do not. And we repeat this and repeat this and repeat this. And by the time we get to a typical course, which may be 20 to 30 treatments, we now have an exponential difference between the effect of the radiation on normal cells, which are basically left behind, and the tumor cells, which are all killed off. And so I like to describe radiation in this way as a selective biologic weapon as opposed to a physical weapon. We're not burning or eradicating tissue where we treat. We're really selectively killing off tumor cells, much in the same way that if we gave an antibiotic, we would be selectively killing off bacteria with a poison, which is more active against the bad actors, the bacteria, as opposed to our body.
No, that's a very cool way of describing it. And it's a good way of thinking about how radiation works, right? And because most people thought it's just very contradictory towards most people's perception about how radiation works. And this is really great. And you mentioned, so a couple of things very important. And you mentioned a lot of this. I just want to sort of capture it and so people can understand it clearly. You're typically a course of treatment for lentigo maligna is about 20 to 30 fractions, meaning they have to come to your office to get the treatment 20 to 30 times. And each time, the planning session takes about 10 minutes or so, but the actual treatment with the radiation is less than 30 seconds or a minute, right? And so that's actually very, very important because that's one of the things that people always afraid of. They think that they somehow have to lie there, not moving for 10 minutes, which is not true, right? It's a really quick type of process. And just another question. So we talked about electron beam. The advantage here is that it's very superficial radiation. You basically want to target the skin very, very, because most of lentigo melanoma is actually very, very superficial. How do you decide 20 versus 30 fractions?
Well, so for this disease, we do have some flexibility. We have in our mind a certain radiobiologic dose that we want to achieve, and that's commonly achievable and achievable with a great side effect profile if we stretch the treatment out to that time frame. But at the same time, we have to consider that these are older patients. And in fact, you can use a shorter treatment schedule if a patient is, for example, if it's difficult for a patient to come out for that many treatments. We can treat with 2 weeks, 3 weeks. The issue here is that, as I was describing, the more you stretch the treatment out, the more selective
Yeah.
the effect becomes, and we're more able to spare the normal tissue. So if we use higher doses per day and treat in a shorter time period, then we do run into more risks of mostly cosmetic effects. So we can leave a blemish on the skin, but sometimes it can lead to some a scarring type issue, or in the worst case scenario, even some breakdown of the skin if the area is vulnerable.
That's what you try to avoid. And then that usually patient comes every day in a week or 2-3 times in a week.
Again, usually daily is an optimal schedule with the weekends off, and that seems to work well both physiologically with the way that our bodies react, and also socially because we're used to having the weekends off, and
Yeah.
patients don't like to come in on weekends, and staff don't either.
Yeah, I was gonna mention that the staff probably doesn't want to come either. No, this is great. I mean, I think one of the things is I had a lot of experiences. We had a lot of patients who just not a good candidate for surgery for the lentigo maligna on the face. We always worked with our radiation colleague